The anatomy of female genital tract consists of external genitalia and internal genitalia. External genitalia, also called vulva, consist of mons pubis, labia majora, labia minora, clitoris, and vestibules, while the internal genitalia consist of vagina, fallopian tubes, and ovaries. Now this is a graphical picture of external genitalia, which consist mons pubis, labia majora, labia minora, clitoris, urethral openings, and vaginal orifice. Now let's talk about external genitalia. The blood supply is provided by internal pudendal vessels. The nerve supply provided by genitofemoral nerve. The development of external genitalia, let's discuss quickly. Clitoris developed from the genital tubercle, labia minora developed from the genital folds, labia majora developed from the labioscrotal swelling, vestibule developed from the urogenital sinus. Now let's talk about Bartholin glands. They are the glands in the posterior lateral walls of the vagina that secretes alkaline discharge while coitus, which is very important for sperm motility, which secretes alkaline, which is very important for sperms. Now vaginal pH is typically acidic, that is 4.5, due to estrogenic activity and lactobacillus bacteria, which is normal inhabitant of vagina. Now let's talk about internal genitalia. The vagina is a fibromuscular canal consisting of 4 walls, 4 fornices, and on the cross section it is H-shaped. Now let's talk about the uterus. It consists of the cervix, isthmus, and fundus, and that is made of 3 different layers: perimetrium, myometrium, and endometrium. The pouch of Douglas is the space between rectum and uterus posteriorly. Now let's talk about fallopian tubes. It is a tubal structure on the both sides of the uterus, almost around 10 cm long. There are 4 parts: the intramural part, isthmus part, ampulla part, and infundibulum part. The ampulla is very important as the fertilization of the gametes happens there. The fallopian tube works for transfer of gametes. Now let's talk about ovary. They are sex gonads of the females. It consists of various size of follicles, which is associated with development and maturation of ovum. Now let's talk about uterine artery. It is very important artery and is a branch of internal iliac artery. So it's very important to know the different branches of internal iliac artery. Internal iliac artery have 2 different segments, that is anterior and posterior. The anterior segments have various branches. These are following: superior vesical artery, umbilical artery, inferior vesical artery, middle rectal artery, vaginal artery, uterine artery, obturator artery, internal pudendal artery, and inferior gluteal artery. While the posterior segment have 3 branches: iliolumbar artery, lateral sacral artery, and superior gluteal artery. This is the picture showing all these branch of the internal iliac artery. Now let's discuss about fundamentals of reproduction. Gametogenesis is very important. The sperm is a gamete of males and the ovum is a gamete of females. The development of sperm from the spermatogonia is called spermatogenesis, and development of ovum from the oogonia is called oogenesis. Now the ovum is arrested into the metaphase. At the time of ovulation, the ovum comes out from the ovary and goes inside the fallopian tube. When it reaches to the ampulla part of the fallopian tube, one of the many sperms will fertilize the ovum and give us zygote. The zygote now develops into morula and into blastocyst. This blastocyst will implant into endometrium, that is called now decidua. The blastocyst consists of outer trophoectoderm and inner cell mass, that's called ICM. The trophoblast eventually develop into placenta and fetal membranes, while the ICM will develop eventually into fetus. Now let's talk about placenta. Placenta is a connection between mother and fetus. Placenta is an assembly of 2 different parts. The first one is chorionic fundosum, which the first one is chorionic fundosum, which makes chorionic plate, and it's developed from the fetus, and the decidua basalis, which form the basal plate, and it's developed from mother. Between these two parts, chorion fundosum and decidua basalis, we have intervillous space. The figures of placenta given here. There are two different kind of circulations in the placenta, the uteroplacental circulation and the fetoplacental circulations. The function of placenta is very important. It gives the nutrition, excretion and respiration to the baby. It has a barrier function which prevents harmful substance to go to the baby. It is a hormonal factory which produces different very important hormones and enzymes too. Now, another important aspect in obstetrics is to understand fetal circulation and the bypasses of the blood at different levels in the fetus. So, from the placenta, oxygenated blood goes through the umbilical vein to the fetus. In the fetus, this umbilical vein will join the portal vein and inferior vena cava, and the bypass here is ductus venosus in liver. Now the blood from here goes through the fetal heart, and in the fetal heart we have another bypass that is called foramen ovale, which passes the blood from right atrium directly to the left atrium. Some of the blood goes to the fetal lungs, where another bypass is there that is called ductus arteriosus, which passes blood from pulmonary artery to aorta. From the aorta, the blood goes to the different parts of the baby's body. Now, from the uterine artery, the deoxygenated blood returns to the placenta. Now, let's discuss some very important physiological changes in the pregnancy. Start with the Braxton-Hicks contraction. They are irregular, infrequent, spasmodic, and painless contraction of the uterus, which happen all the time in pregnancy. This very contraction changes into labor pain at the time of delivery. Now, very important skin changes are linea nigra and stria gravidarum. Now, let's discuss some weight gain in pregnancy. Total weight gain in pregnancy is almost around 11 kg. In first trimester is around 1 kg, and in second and third trimester it is around 5 kg weight gain. Now, important hematological changes are blood volume increases by 30 to 40%, plasma volume increases by 40% and sometimes even 50%, while the RBC volume increases by 18 to 20%. Total hemoglobin of the body increases, but hemoglobin concentration is decreased, so that we can sometimes find hemoglobin level in the pregnancy can be decreased. Now, very important cardiovascular changes. Cardiac output increases, blood pressure remains normal, pulse increases, systemic vascular resistance decreases. There is a decrease in motility of gastrointestinal tract, which leads to various problems like constipation in pregnancy. Thank you. Let's discuss diagnosis of pregnancy. The duration of pregnancy remains 9 calendar months plus 7 days, or 280 days, or 40 weeks. The calculation of gestational age starts from the last menstruation period, that is called LMP. Now, the first trimester, which lasts from 0 to 12 weeks, is very important as the organogenesis happens in this trimester. There are various signs in the first trimester described like Jacquemeyer signs, which shows blue vagina due to congestion of vaginal veins. The Osciader signs, which shows the increased pulsation in the vagina, and the Goodell signs, which shows soft cervix. The uterus size is increasing with the gestational age. It can be measured with the bimanual examination in per vaginal examination. So at 6 weeks it is around hen's egg, at 8 weeks it's around a cricket ball size, or at 12 weeks it's around fetal head size. Now there is another sign that is called the Cox signs, which shows the asymmetrical enlargement of the uterus, which can be elicited from the bimanual examination, as the one half is more firm than another due to lateral implantation in the uterus. Another very important sign is Hagar signs, can be elicited from the bimanual examination. Palmer signs, that shows the regular rhythmic contraction of the uterus, but these Hagar signs and Palmer signs are nowadays not done, if not very must. Now the diagnosis of pregnancy nowadays, the two important aspects are there: measurement of beta HCG or ultrasound, that is transvaginal ultrasound. The beta HCG increases can be detected by urinary pregnancy test or directly the blood serum levels. The USG transvaginal ultrasound is very sensitive for first trimester diagnosis of pregnancy. Now the second trimester lasts from 13 weeks to 28 weeks. Quickening, which is feel of life, happens at around 18 weeks. The uterine size has been increasing, so the uterine fundus height is very important in diagnosis. The gestational age of the mother with help of simple clinical examination. At 12 weeks, it reaches to the symphysis pubis. At 24 weeks, it reaches to the umbilicus. At 38 weeks, the fundus goes up to the xiphistern. Now the fetal heart rate. Fetal heart rate clinically you can hear by stethoscope after 18 to 20 weeks, but at earliest point of time by color Doppler and transvaginal ultrasound, the earliest fetal heart can be seen by 5 to 6 weeks. The normal value of FSH is 110 to 160 per minute. If it is less than 110, it is called fetal bradycardia. If it is more than 160, it's called fetal tachycardia. Another very important part in second trimester is an anomaly scan, that is an ultrasound directly specifically targeted for any anomaly in the baby, and it's done at 18 to 20 weeks, sometimes also called anomaly scan. In the third trimester, that starts from 29 weeks and ends at the 40 weeks, important sign sometimes is lightening. Lightening can be seen in the first in the primary patient when the sense of relief is filled because of engagement of head of the uterus. Again, the third trimester that lasts from 29 weeks to 40 weeks, and some important signs like lightening can be seen in this particular trimester. It is a sense of relief to the mother due to engagement of fetal head into the female pelvis. Now let's discuss some important diameters of maternal pelvis and fetal skull. In the maternal pelvis, the shortest anterior-posterior diameter is obstetric conjugate, that is 11 centimeter. The transverse diameter, which is shortest, it is the distance between two ischial spines, that is around 9.5 to 10 centimeter. If we talk about fetal skull, the anterior-posterior diameter changes according to the position and attitude of the fetus, and the transverse diameters relatively remain same while vertex presentation. The shortest is biparietal diameter, and the anterior-posterior diameter in fully flexed vertex position is suboccipito-bregmatic diameter. This is here, that is 9.5 centimeter. And if the face presentation is there, then again the shortest diameter, that is submentobregmatic, is also 9.5 centimeter. If the head is not very flexed or deflexed head, then the diameter changes, that remains verticomental diameter. In brow presentation, verticomental diameter is there, that is 13.5 centimeter, which is very big diameter as compared to the other diameters. So these are the important diameters. In all normal situations, submentobregmatic diameter is the engaging anterior posterior diameter, and the transverse diameter remains a biparietal diameter, that is around 9 to 10 centimeter. Now let's talk about normal labor, that is called eutosia. Now let's start with the definition. Series of events that take place in the genital organs in effort to expel the viable products of conception, that is fetus membrane and placenta out of the womb through the vagina into the outer world. It's called labor. Now the abnormal labor, it's called dystocia. Labor must fulfill the following criteria. It should be spontaneous, it should be with vertex presentation, it's without undue prolongation, the natural termination with minimal aids, and it's without any complications. Now let's understand the very important difference between false labor pain and true labor pains. The false labor pains are dull, continuous, no uterus hardening is seen, cervix is not dilated, not effaced, and those kind of pains are relieved generally by the enema. While the true labor pains are painful, rhythmic, dilatation of cervix and show is there, effacement of the cervix is seen. So this is called true labor pains. Now let's talk about the 4 stages of labor. The first stage starts with the true labor pain and ends with the full dilatation of the cervix. It takes around 12 hours in the primary patients and around 6 hours in the multigravida patients. The second stage starts with the full dilatation of the cervix and ends with the expulsion of the fetus from the birth canal. In primary it takes 2 hours, while in multi it takes only 30 minutes. The third stage begins with the expulsion of fetus and ends with expulsion of the placenta and its membranes. Generally it takes 15 minutes when it is passive. When we do active management of third stage labor, it's around only 5 minutes. Now the fourth stage is the observation of 1 hour after the third stage, mainly for the purpose of bleeding. It's the observative stage. Now let's talk about the mechanism of the labor. It's very important to understand. Engagement, that means that fetal head enters into the pelvic brim through transverse diameter of the pelvis. Now comes a descent. Descent is a continuous downwards movement of the fetus from uterus towards the vagina. The flexion, that means the attitude of the fetus should be more and more flexed, because once the fetal head is more and more flexed, the smaller diameter of fetus is available for engagement, which is very easy. Now, internal rotation of the fetal head of around 90 degree happens at the spine level, or it's happen at a 0 stage of the labor. So this is very important, so labor can go ahead. Now the crowning, maximum diameter of the head stretches out the vulva, that is called crowning. Now the extension, delivery of the head of the fetus by extension of the movements. Now restitution, passive movement of head towards the maternal thigh to relieve the neck twist. It's called restitution. External rotation, rotation of the shoulder towards the thigh. It's called external rotation. Birth of the shoulder and trunk. So this was all about normal labor. Postpartum hemorrhage is increased blood loss beyond the limits after the baby is delivered. In normal delivery, the cutoff is 500 ml, and in the cesarean section, the cutoff is 1000 ml. Now, the reasons of PPH, the very important reason is hypotonic uterus. Now, there is a concept of living ligature between the muscle fibers. The blood vessel is sealed, but if the uterus is not contracted or it is relaxed, then this blood vessel will not be sealed and bleeding will be there. Residual product of conception like bits of fetal membrane and placenta can also cause PPH. Clotting problems like anemia can also cause PPH. Aortic injury like injury due to episiotomy wound, injury due to forceps, ventouse, all this can cause PPH. Cervical tear also cause PPH. Now, the prevention of PPH is very important in obstetrics and it is a central stone of obstetrics. So the thing comes is AMTSL, that is active management of third stage of labor to prevent postpartum hemorrhage. And what are the components of AMTSL? The first one is oxytocin, intramuscular 5 units, IV 10 units in drip as soon as the anterior shoulder of the baby is delivered. Controlled cord traction and placenta should be delivered, followed by inspection whether any beads are not left. Inspection for the injury of uterus, cervix, vagina and vulva. This will do AMTSL. Now, what if even after AMTSL PPH happens? What you should do? Then the IV oxytocin should be continued. Tablet misoprostol, that is a prostaglandin, 800 microgram per vaginal should be kept. Injection carboprost, that is also a very potent prostaglandin. IM injections are available. Uterine massage should be given. Tranexamic acid has also some role, and blood transfusion if anything does not work. Okay, so even after blood transfusion PPH continues, then you can go for balloon catheter, balloon tamponade. If it is even not possible, or if it is even not available or not expertised, then uterine artery embolization can be done with the help of radiology, but this procedure is also not available at all the places. Uterine artery ligation by doing laparotomy can also be tried, and at the end, if anything does not work, then you should go for obstetric hysterectomy to save the life of patient. Now, hyperemesis gravidarum. Small amount of vomiting in pregnancy is okay, but if it is more than too much, it is called hyperemesis gravidarum. It is associated with fluid loss, mineral loss and electrolyte imbalance and day-to-day problem in life. So the treatment required is admission into the hospital, fluid therapy, antiemetic drugs, electrolyte imbalance correction. Now let's discuss abortion. Abortion means aborting the pregnancy before 20 weeks or the fetal weight less than 500 grams. Now it can be either spontaneous or induced. In the induced, it can be medically induced, or if simply the patient does not want pregnancy. Now, the spontaneous abortions are of various types. The first one is threatened abortion, in which the process of abortion has been started but the child can be saved with the higher progesterone support, and that makes the treatment of threatened abortion. The inevitable abortion, that means the process of abortion has been started, the fetus has been dislodged, now nothing can be done. What can be the treatment? It is to complete the abortion either by medically with oxytoxics like misoprostol, oxytocin, or surgically by dilatation and evacuation. The incomplete abortion, that means there are still retained product of conceptions present in the uterus. Uterus is not totally empty. The treatment is same as inevitable abortion. Now the complete abortion, that means the abortion process has been completed and there is no RPOCs inside the uterus. Uterus is completely empty and no treatment as such required for complete abortion. Now what is missed abortion? There is no viable fetus present in the uterus. For example, there can be only G-sac but no fetal pole, or if the fetal pole is present but no cardiac activity has still there even after 7 or 8 weeks. But here the process hasn't started. The process of abortion hasn't started yet. Now what is the treatment? Induction of abortion with prostaglandins and oxytoxics are the treatment of choice. Or if it is not there with this medical treatment, you can go for surgically dilatation and evacuation. Now ultrasound or sonography makes the investigation of choice for any abortion. Now let's discuss something about recurrent spontaneous abortion. It is a problem with many couples and there can be divided by weeks. Less than 12 weeks the cause remains the genetic cause, and in the cases of more than 12 weeks of multiple abortions, spontaneous recurrent abortions, uterine cause is the main cause of problem. Even Mullerian abnormality can be there, cervical incompetence can be there. Now the treatment of spontaneous recurrent abortion remains to identify or diagnose the cause of particular abortions. How to investigate? You can go for some genetical problems with karyotypes and some microdeletions in the chromosomes, or you can go with hysteroscopy or 3D ultrasound, which will diagnose any uterine factor present or not. The treatment can be pre-genetic diagnosis with in vitro fertilization can be done. Thank you, friends. Now let's discuss ectopic pregnancy. Implantation of the pregnancy occurs other than the uterine cavity, that is called ectopic pregnancy, where the tube remains the most common site, followed by ovary, followed by abdomen, and followed by cervical ectopic pregnancy. Uterus is a particular organ which can withhold the pregnancy and can continue grow longer and longer. But other than uterus, pregnancy can be established but can't go longer, and that's why it aborts. So there are symptoms of abortion in ectopic pregnancy like vaginal bleeding and abdominal pain. Now, the growing pregnancy in tube can increase in sufficient size and can rupture the tube, and this will lead to hemoperitoneum, and this will in fact lead to hypovolemic shock, and that makes an ectopic pregnancy as an obstetric emergency. Now ultrasound remains the mainstay of diagnosis. You can find any pregnancy in adnexa, you have an empty uterus, and decidual reaction is present without any pregnancy. Now treatment remains on the status of tubal rupture. If tubal rupture has been occurred, then you have no other option to go for either laparoscopy or laparotomy, and salpingectomy or milking of ectopic pregnancy should be done. If hypovolemic shock is there, then it can be managed with blood products, fluids, and routine ICU management. If tubal rupture has not been occurred, but if you think it is likely to going to be occur and it cannot be medically managed, then you can again go for laparotomy or laparoscopy. If you think that the pregnancy or the ectopic pregnancy can be managed with conservative management like methotrexate and folic acid, you can go for either medical management too. Now the medical management done with methotrexate along with folic acid, and extensive monitoring should be done. Extensive monitoring for tubal rupture should be done. Now let's discuss something about beta HCG. Beta HCG is a hormone that's secreted by the trophoectoderm. Now beta HCG increases 66% in every 48 hours in successful pregnancies. Now at 1500 value of beta HCG, you must identify a pregnancy at transvaginal ultrasound, and if there is a value of 5000, you must find the pregnancy on transabdominal ultrasound. So beta HCG, serial beta HCG values are also very important in diagnosing and treating the ectopic pregnancy. Now let's discuss hypertension in pregnancy. The hypertensive disorder in pregnancy can be either two types. It can be chronic hypertension, in which the BP is already increased even before the pregnancy. So patient is hypertensive before getting pregnant. And the second one is pregnancy induced hypertension, in which blood pressure goes more than 140/90. There are three different stratas of this pregnancy induced hypertension, starting with gestational hypertension, which is a blood pressure more than 140/90. There is no proteinuria and no seizure. Second one comes the preeclampsia, in which two different category of mild preeclampsia and severe preeclampsia is there depending on the blood pressure limits, and there is the proteinuria. No seizure is seen in preeclampsia, but there are symptoms like abdominal pain, chest pain, edema, headache, and unclear vision are the symptoms of severe preeclampsia. And the third one comes the eclampsia, in which the hypertension in pregnancy is complicated with the seizure disorder, that is generalized seizure, along with decreased platelet counts. Now pathophysiology is now very clear and important. that it is due to placental toxicity. The capillary permeability increases, which allows the proteins to get out from the intravascular volume that will cause you edema and various coagulative problems. The complications are very grave, like fetal loss, neural injury, pulmonary edema, and even death. The investigation of hypertensive disorder remains the complete blood count, in which you will find increased hemoglobin concentration, platelet can be decreased, dearranged liver function test and kidney function test. On urine routine and microscope you will find proteinuria, and on 24-hour urine protein is very important to diagnose or establish diagnosis of proteinuria. On ultrasound you will give more importance on colored Doppler or fetal colored Doppler to make the fetal status reassuring. The CTG, that means cardiotropography, should be done frequently in this kind of patient to again reassure the fetal status. Now, management of hypertensive disorder in pregnancy remains: the first is control of blood pressure. The labetalol is a drug of choice. It is available as oral tablets and also intravenous dose. The next important medicine is magnesium sulfate. Is very important for severe preeclampsia and eclampsia. It can prevent seizure disorders. Now, the pre-chart regime is followed, in which 14 gram of magnesium sulfate given stat, followed by 5 gram of magnesium sulfate 4 hourly. Now, the definitive treatment of severe preeclampsia and eclampsia always remains the termination of pregnancy, either by cesarean section or vaginal delivery, whichever early is possible. Now, the gestational hypertension or mild preeclampsia can be treated with mild efforts like increased monitoring, BP control, and fetal status reassuring maneuvers. Now let's discuss antepartum hemorrhage, that is bleeding before delivery of the baby. It can be most of the time due to problems of placenta. Two main problems of placenta are there. The first one is placental abruption and the second one is placenta previa. In the abruption, placenta dislodge from the uterine wall, and in the placenta previa, placenta implanted in the lower uterine segment, so that minor amount of uterine readjustment happens and placenta dislodges for some of the area and gets bleed. In the placental abruption, once the abruption is there, the placenta cannot be re-established. So baby have decreased blood supply and even intrauterine death can happen. So once you find out there is a placental abruption, it becomes a medical or obstetrics emergency and you have to go for cesarean section or vaginal delivery, whichever early possible. Now in this particular case, uterus is woody hard, the FSH means fetal heart sound goes decreased, the pain abdomen is there. In the placenta previa, there is a painless bleeding is there, uterus is soft, and FSH can be heard well if no more or very excessive bleeding has been happened. Now the placenta previa can be either complete, in which no chance of vaginal delivery is there, you must go for cesarean section, and it can be partial, in which a minor chance of vaginal delivery is there. The primary management of placenta previa is to stop the bleeding with injection tranexamic acid, vital monitorings, fluid replacement, and fetal status reassuring. Now the definitive treatment of placenta previa is delivery. Okay, if the baby or if the pregnancy has achieved 37 weeks, then you should go surgically termination of the pregnancy and delivery of the baby. If the baby is still not reached at 37 weeks, then you can go for conservative management, that is called McPhee regimen in some cases only. Which are those cases? In which the patient is hemodynamically stable, no active bleeding is seen, fetus is okay, and still there is a preterm status. Now let's discuss diabetes in pregnancy in short. The diabetes mellitus is basically a sugar intolerance, and if it is there before getting pregnant, then it is simply called diabetes mellitus in pregnancy. And if this glucose intolerance or sugar intolerance is identified first time in pregnancy, then it is called gestational diabetes mellitus, that is GDM. Now the diagnosis of GDM remains the glucose challenge test. This glucose challenge test is done by 75 gram or sometimes 50 gram of glucose and blood sugar measurement after 2 hours of intake of those 50 or 75 gram of glucose. If it is come less than 120, then it's taken as a normal. If it is 120 to 140, then glucose intolerance is diagnosed and it can be treated with diet control and exercise. If it is more than 140 mg per dl, then gestational diabetes mellitus diagnosis is established and it can be managed with insulin and oral hypoglycemics. If it is more than 200, then the overt GDM is diagnosed, in which you need hospitalization and strict insulin controlled sugar control. Now one which very important investigation is important to discuss here is HbA1c, which gives you the 3 months of sugar control and it should be less than 6.5%. Now there are various problems with diabetes mellitus or GDM in pregnancy. Those are very grave too. For example, congenital malformation chances are higher, sudden IUD can happen, term IUD can happen. The baby born with macrosomia, that means the fetal weight is more than 4.5 kg, which causes problem in delivery too. So diabetes mellitus is very important to know in pregnancy. Now let's discuss Rh negative pregnancy or rhesus negative pregnancy. In rhesus negative person or Rh negative person, on the RBCs there are no Rh antigens and in the plasma there is no Rh antibody is there. So if a female with Rh negative blood group becomes pregnant with the Rh positive baby first time, no problem arises to the first baby. But if the exposure of Rh antigen to the Rh negative mother happens either by previous transfusion, previous conceptions with Rh positive babies, this will lead to formation of Rh antibodies into the mother. And when the mother gets second pregnancy, these Rh antibodies will travel to the baby along with the placenta, and that they will do rupture of all Rh positive RBCs of the baby. So eventually there is a hemolysis in the baby and fetal anemia will develop and it can lead to even death or IUD. Now what is the management? If you find out Rh negative mother, and if you find out yes there is a possibility of Rh positive baby, then on the booking visit or booking scan you will go for indirect Kumb test, that is ICT, so to know the anti-Rh antibody presence in mother's blood or not. If they are not present, if the test comes negative, then everything is okay, just repeat ICT at 28 weeks. But if it is positive, then you must find that how much amount, that means titer of the Rh antibodies present in the mother. Okay, now the treatment and prevention remains the same. The prevention is giving passive immunization with anti-D antibodies to the mother. How it will work? It will stop mother's own immune system to develop its own Rh antibody, and whenever exposure of Rh antigen to the mother present, you must give anti-D antibodies. The dose remains almost 3 microgram international units IM. Now, the treatment of already affected baby can be fetal status monitoring with fetal anemia screening or hemolysis screening or Doppler of MCA, that is middle cerebral artery, in which you will find increased flow. If you find that that there is very much hemolysis present in the baby, then you can go for intrauterine transfusions too. Now let's discuss obstetric examination. After doing general examination, you will do per abdomen examination. On the per abdomen examination, you will measure fundal height, and the fundal height of the uterus correlates with the gestational age. Okay, when the uterus or fundal height reaches up to symphysis pubis and uterus become just palpable, the gestational age will be counted as a 12 week. When the uterus fundus reaches up to the umbilicus, the gestational age will be counted at 24 weeks. When the uterus or fundus reaches up to xiphisternum, then it is a term pregnancy. It can be counted as either 36 weeks or 38 weeks or even at 40 weeks. Okay. Now there are 4 maneuvers, also called Leopold maneuvers, to know the position and presentation of the baby. The first Leopold maneuver is a fundal grip. The second Leopold maneuver is a lateral grip. The third Leopold maneuver is a pollic grip, and the fourth maneuver is pelvic grip. After doing this examination, you will definitely know the position and presentation of the baby, like vertex, breech, transverse lie, like that. And with this thing, you can also predict the site of FSH, that is fetal heart sound. The fetal heart sound is heard by stethoscope, the bell of stethoscope. It should be first measured on LOA, that is left occipito-anterior position. It is like here in the figure, which is the most common position of FSH. Okay. Now comes the per speculum examination. It is an inspection of internal genitalia, that is vagina, the cervix and the fornices. You can see the cervix. You can see whether the os, the external os which is seen on the per speculum examination, is open or not. You can also see any membrane coming out there. You can also see any discharge coming out from there also there or not. So that is a per speculum examination. On per vaginal examination, which is a very important examination in obstetric examination, you will definitely palpate the cervix. You will see the dilatation, the effacement of the cervix. You will also assess the pelvis. And how will you assess the pelvis? The distance between two spines. It should be at least 4 fingers. Now, to assess the pelvis for what? Cephalopelvic dispersion, that is CPD. Now the CPD can be either mild degree or severe degree. If you find that the CPD is a severe degree one, then you should go for cesarean section directly. You should not attempt to go for vaginal delivery. If you find that there is only mild degree of CPD, then you should refer this patient to the higher center, or the delivery should happen at higher center. Because when you give a trial of labor, that is called TOL, trial of labor, if anything happens or if anything goes problematic, if the labor progress is stopped, then you can go for emergency cesarean section. That's why you refer to higher center, or this kind of delivery should be only done in higher center. If it is success, then it's okay. If it is not, emergency cesarean section should be done. So this was the obstetric examination. Now let's discuss induction of labor. Induction of labor is a manual starting of the sequence of the actual labor. That means we are starting the sequence of labor manually, which should be ideally spontaneous. And when we should go for IOL, wherever the baby has more survival chances outside than inside of the uterus, in the conditions where the maturity is achieved with diabetes mellitus either, preeclampsia, postpartum pregnancy, liver problems, and higher bilirubin rates, or any problems, medical problems in the pregnancy. When it comes to term, if the baby has achieved enough maturity, then you can start the induction of labor. Now IOL is done by 2 different kind of oxytocins. The first one comes is a prostaglandin. Prostaglandins help with the cervix. That means The dinoprost gel and misoprost tablet are actually useful for effacement and dilatation of the cervix and initiation of the initial contractions, uterine contraction. Then after enough effacement and dilatation of the cervix, oxytocin takes the charge. Now during the IOL, you have to monitor for the fetal status and also for the progress of the labor. Now one thing is very important is partogram. Partogram is a graphical documentation of the progress of labor to detect the prolonged labor earliest. So the only point here with the partogram is we can detect the prolonged labor earliest possible. The normal rate of progress, it should be 1 centimeter per hour. So this is all about the IOL. Now let's discuss preterm labor, PTL. Technically, any labor before 37 weeks of the pregnancy is called preterm labor. Now remember one important milestone for the fetus, that is 34 weeks. At the end of 34 weeks, the fetal lung maturation is almost complete. What can be reasons of the PTL, preterm labor? In the most of the cases, it is idiopathic. Maternal stress and disease can also do PTL. Premature rupture of membrane is also an important factor. Incompetent cervix, which is also important, for which cervical encerclage is done before at or around 12 to 13 weeks. Any inflammation in the mother's body can start PTL. Okay. Now, what are the treatment options? Unfortunately, once the labor sets in, we have a very small amount of treatment options for PTL. The important ones are rest. Second is, if the gestation age is less than 34 weeks, then you should give steroid to get the lungs matured. Injection betamethasone 12 mg 24 hours apart. Now the steroid takes some 2 to 4 days to act and get the work done. So for this time you should try to maintain the baby inside the uterus. Now the tocolytics, which are uterine relaxants, available in oral and intravenous form, that is nifedipine and duodenum, can also be used. Antibiotics are very important here because it will prevent infection and chorioamnionitis. Fluid should be given. Keep everything ready. That means the patient should be admitted nearby labor room. Pediatrician should be also informed, and an ICU bed, that is neonatal ICU bed, should be arranged. So these only options we have for PTL. Now let's discuss twin pregnancy. The twin pregnancy can be of two types, either monozygotic or dizygotic. The dizygotic twin pregnancy will always be dichorionic and diamniotic, while the monozygotic twin pregnancy can be either dichorionic, diamniotic, monochorionic, diamniotic, or monochorionic, monoamniotic. Now the problems with twin pregnancy are various. Twin pregnancy is definitely considered as a high risk pregnancy because there are chances of malpresentation, prolonged labor, postpartum hemorrhage, preterm labor, premature rupture of membrane, uncontrolled GDM, uncontrolled hypertension, and the risk of intrauterine death. The management and the delivery program is dependent on the presentation of the first baby, and the first baby is a low Vernon baby. If the first baby is vertex presentation there, then the vaginal delivery is allowed, but if it is not vertex, then directly cesarean section should be considered. After delivery of the first baby, if the second baby is also vertex and gets delivered easily, then it's okay. But if the second baby is a breech or even transverse presentation, then there is going to be a very difficult problem. Now the one thing called internal version should be attempted at this particular point, which is described in the books. But nowadays any kind of version, that is either internal version or external version, are not done. And if anything happens like breech presentation or transverse, if breech presentation is not easily delivered, then this patient at this point of time also should go for cesarean section. Now let's discuss about version something. Version is nothing but changing of the baby's position manually. It can be done externally, that is called external version, or internal, it called internal version. The external version was done in past where cesarean section was not readily available, in which the breech or transverse presentation babies were inverted, were version done and taken into vertex position. Internal version, the only indication right now today remain is a second baby of twin pregnancy only. But believe me, these maneuvers are not very safe and they can be dangerous for baby. Placental abruption and cord prolapse can happen anytime. So you should not go for this thing unless you are very, very, very experienced with these things. Now let's discuss about something about the cord prolapse. The cord comes out before the baby itself. So it comes out from the narrow cervix, so there are chances of compression of the cord. And once the cord is compressed, everything that is supplied to the baby is stopped and the baby can die into minutes. So this is a very grave complication. So all with this thing, you should always manage this kind of twin pregnancy in the higher centers only. Also the babies that are born with either twin pregnancy or even or multiple pregnancy tend to have low birth weight, and that's why proper neonatal care or proper pediatrician care should also be arranged. The beds in the NICU should be arranged. Now let's discuss malpresentation. Anything other than vertex presentation, occipito-posterior position and flexural attitude is called malpresentation. Now let's discuss occipito-posterior position. In this position, the occiput of the fetal head lies in the posterior part of the female pelvis, which should be ideally on the anterior one. So mechanism of labor in this position, in most of the cases, anterior internal rotation of 2/8 of the circle happens and the baby gets delivered normally. In some of the cases, transverse arrest has been happened, in which you have to go for cesarean section, because in the 99.99% cases, progress of the labor will be stopped. If the fetal head rotates, internal rotation happens posteriorly of 1/8 of the circle, then it becomes occipitosacral position, in which the face tube pubis delivery can happen. Now the second one is breech presentation. Breech presentation literally means the position of breech in the LUS, which ideally should be occupied by the vertex. So the types of breech presentation are frank breech, complete breech or incomplete breech, or even also called footling breech. In the frank breech, the problem comes after coming head delivery, because this frank breech, the buttocks and thighs and the trunk can be easily delivered, but the cervical os is not that much dilated and the after coming head can be stuck. The complete breech is very favorable for the vaginal delivery. You should always go for vaginal delivery with complete breech. If the breech is a footling, then you should not try to go for vaginal delivery. You should directly go for cesarean section, because the chances of after coming head stuck are very, very high in this kind of breech presentation. Now the mechanism of labor, the engaging diameter remains the bitrochanteric diameter. Descent of the buttocks happens. Buttocks and trunk can be easily delivered, but the problems comes delivery of after coming head, and which is very important and vital. There are various maneuvers, various bridge extraction procedures described to deliver the bridge. But what important most is your experience with this kind of delivery. If you have slight doubt about this thing, then you should not try to deliver this kind of bridge patient. You should refer it to the experienced surgeon or go for cesarean section. Now the third one is transverse lie. The transverse lie position of the baby is very, very dangerous because there are higher chances of cord prolapse. And so that you do not attempt normal vaginal delivery, do not attempt version in this case, directly go for cesarean. Now let's discuss low birth weight baby. The low birth weight baby is called when the birth weight of a baby is less than 2500 grams. The very low birth weight is called when the birth weight is less than 1500 grams. And extremely low birth baby is called when the birth weight is less than 1000 grams. Now this can be mainly due to two things. The first one is prematurity, in which the baby is delivered less than 37 weeks, and the second is growth restriction, or called intrauterine growth restriction, that is IUGR. If the growth of the baby at any time in the uterus is less than the 10th percentile of what is normal, then it is diagnosed at IUGR. Now what can be the reason of IUGR? It can be only due to two main things like placental insufficiency and chromosomal abnormality like Down syndromes. The diagnosis is made by the uterus, and the treatment is very crucial part here, because if the baby's gestational age is more than 38 weeks and baby is of sufficient weight, then you can go for vaginal delivery. Also check the status for lung maturity. Okay, now if the baby if the gestational age is less than 38 weeks, then you should ideally concern about the fetal lung maturity, in which you will go for steroids like betamethasone to achieve the maturity cesarean section. With the low birth weight baby, always the concept remain is like you should not give the baby which is very weak the stress of delivery, so that you should directly go in cesarean section with this kind of babies. Also alert your pediatrician for upcoming baby and also arrange an ICU bed. Now let's discuss some operative procedures in obstetrics. Three procedures we are going to discuss. The first one is cesarean section, second is dilatation and evacuation, and the third one is episiotomy. Now let's discuss cesarean section. In the cesarean section, you will start with the skin incision, followed by subcutaneous tissue dissection, rectus sheath incision, then rectus muscle lateralization, then peritoneal incision, then bladder should be separated from the lower uterine segment, then the uterine segment, and here the uterine segment incision is phalangeal incision, and then delivery of the baby and other products of conceptions like placenta and fetal membranes, then suture back the uterus, peritoneum, rectus sheath, and then at the last skin. These are the steps of cesarean sections. 3 days of hospitalization is required after cesarean. Now let's discuss about episiotomy. It's a very common procedure done in obstetric unit. Now we are giving mediolateral episiotomy. When should we give episiotomy? Remember, when the crowning is there, only then at that time you should give episiotomy. Now the structures which are broken in episiotomy are vaginal epithelium, various perineal muscles, and perineal skins. Now for repairing of these particular structures, you have to start from the basic with vaginal epithelium, followed by the muscles, and then after perineal skins.